Xin chào tất cả các bạn. Ung thư thực quản là một trong những loại ung thư phổ biến của đường tiêu hóa. Xạ trị đóng vai trò quan trọng trong điều trị gần như hầu hết các giai đoạn như là hóa xạ trị tiền phẫu, hóa xạ trị triệt để hoặc là xạ trị giảm nhẹ. Hôm nay chúng ta sẽ được bác sĩ Christopher Holmier đến từ khoa xạ trị của Mayo Clinic trình bày về vai trò của xạ trị trong ung thư thực quản dạ dày. Chúng ta cùng bắt đầu nhé.
Thanks, Dr. Blackman, for the kind words, and thanks to you and Dr. Groats for the invitation to speak today. I'm going to talk about radiation therapy in general, and then also spend a lot of time talking about proton beam therapy specifically, which I think has significant promise for esophageal cancer. So we'll discuss the role of radiotherapy for gastroesophageal cancer just from a more broad perspective. We'll talk about some of the side effects that patients experience while they're getting radiotherapy for gastroesophageal cancer. And then we'll talk about some of the advances in radiotherapy techniques, specifically proton beam therapy. So just going to start with a case. This is a patient that I saw a couple years ago, a 78-year-old woman who had presented with new epigastric pain and anemia or decreased hemoglobin. She underwent an evaluation and was found to have a mass in the lower esophagus. This is the endoscopic picture, and this is a tumor right here. This is the normal esophagus over on this side. This was biopsied and found to be an adenocarcinoma, which is the most common type of cancer that arises in the lower esophagus. She underwent a staging evaluation, and it was found that the tumor invaded a fair distance into the wall of the esophagus. These are scans. This is a whole body PET scan, and the tumor is shown here in the distal esophagus, and you can also see in this view here. This is felt to be a stage 2 esophageal cancer, meaning it grew deep into the wall of the esophagus, but there was no evidence of spread to any surrounding organs. Given her age, and she did have some underlying comorbidities, it wasn't clear whether she'd be a candidate for an esophagectomy, and quite frankly, she was hesitant to consider an esophagectomy. So we treated her with combined chemotherapy and radiation, and then a plan to reassess and decide whether to proceed with an esophagectomy. So she was treated with proton beam radiotherapy, which was given in 25 treatments, once daily over 5 weeks. She received weekly chemotherapy with carboplatin paclitaxel. This is the radiation treatment plan. This is a few different angles. This is showing a cross-section, as Dr. Yoon nicely described, with the front of the patient here, the right here, the left there. And with the proton beam therapy, we have 2 beams that come from the back through the table and deposit the radiation dose. The red is the highest dose of radiation, and then yellow, green, and blue are lower doses of radiation. So you can see we targeted the tumor and then the surrounding lymph node areas. She tolerated treatment reasonably well, developed some fatigue during the course of treatment, had some loss of appetite, some pain with swallowing, and lost about 10 pounds of weight, but we're able to support her with dietitian support, modification of her diet, fluids, and she got through treatment and then recovered. She came back about 2 months after treatment, and the tumor in the esophagus had significantly shrunk in size. There's just some residual mucosal changes here, and on the imaging, the tumor has substantially shrunk. Given, again, her age and comorbidities, she elected to carefully watch things as opposed to go forward with an esophagectomy, and she's now over 2 years out and is disease-free and has good swallowing function, but is in a close surveillance program. So how does radiation therapy work? As we mentioned in the case example, the patient came in for daily radiation treatments over a 5-week period. The patient lays on a table, and the radiation machine rotates around from several different angles, targeting the tumor and the surrounding tissues that are felt to be at risk. It doesn't hurt to get a radiation treatment. The patient basically lays there and it's kind of like getting an X-ray. Radiation causes damage to the DNA of the tumor cells. The DNA is responsible for having cells replicate. It's sort of the master plan, the blueprint for the cell. And so if a cell wants to divide or duplicate itself, it has to replicate the DNA. So radiation causes damage to the DNA of cancer cells, such that when it tries to replicate itself, it's not able to do so, and the cell dies off. And then as the cancer cells die off, that can result in the tumor itself shrinking. The DNA injury is done immediately or nearly immediately when a patient gets a radiation treatment, but this process of the cancer cells dying off and then ultimately a tumor shrinking on scans, that process can actually take days, weeks, or months. So typically if we treat a tumor with radiation, we would need to monitor it for several weeks or months afterwards, and it's over that time that we would expect to see shrinkage of the tumor. Radiation is not a new treatment for esophageal cancer. It's actually been used for over 100 years. This is a publication from Mayo Clinic in 1920 from Dr. Vinson. And he describes a technique for doing radium treatment for esophageal cancer. So as early as 1920, here at Mayo Clinic, they described successful treatment of some patients with esophageal cancer or palliation of swallowing problems with radium treatments. Of course, we've come a long way in the past 100 years, and a lot of research has been done, and this is the current status of how radiation is used for esophageal cancer. For patients that have localized or locally advanced but non-metastatic tumors, if they're a candidate for an esophagectomy, the standard treatment approach is to give chemotherapy and radiation first to shrink the tumor and then do an esophagectomy. If patients are not good candidates for an esophagectomy, then we would consider doing chemo and radiation as the sole treatment and then observe them afterwards. And for patients that have metastatic cancer, the cancer is spread to other parts of the body. Radiation can still be a useful treatment for dysphagia or difficulty swallowing caused by the tumor. Even if it's not able to cure the cancer, it can cause the tumor to shrink and help open up the esophagus to allow patients to be able to continue eating. I'm just going to review from a high level a couple of the key studies that have established the role of radiotherapy in these different contexts. This is a very important trial that was done about 10 years ago in the Netherlands. It's called the CROSS trial. And it really established the role of doing chemotherapy and radiation before surgery for patients that have localized or locally advanced tumors. So in this study, they took almost 400 patients who had a localized and operable esophagus or gastroesophageal junction tumor. And it was the flip of a coin. If they got heads, they went straight to having a surgery or an esophagectomy. If they had tails, then they got a regimen of chemotherapy and radiation over 5 weeks, and then approximately a 6-week rest period, and then surgery. So this was surgery alone versus multimodality or trimodality because of using 3 different treatment methods, so chemotherapy, radiation, and surgery. So this trial compared these 2 approaches to the treatment of esophagus and GE junction cancer. What they found is that the patients who had the concurrent chemotherapy and radiation did have side effects from the treatment. The most common ones were tiredness, a drop in blood counts, nausea, and weight loss. Most patients had these to some degree, and about 10% or so had fairly significant or symptoms that required hospitalization. What they found is that the patients who had the trimodality therapy or had the chemo and radiation before the surgery were much more likely to have a margin negative or what's considered a curative resection. The patients who went straight to surgery, about 70% of the time they had a margin negative resection, or conversely 30% of the time when the surgeon removed the cancer, there were cancer cells at the edges of what they removed. Whereas the patients who had chemotherapy and radiation beforehand, about 92% of those had clear margins, meaning less than 10% of the time there was cancer at the edges of what the surgeon had taken out. And that's because the radiation and the chemotherapy given before the surgery killed off a lot of the cancer, such that there wasn't as much left behind when the surgeon went in and removed it. And again, it was less likely that there would be cancer left behind. Similarly, giving the radiation and the chemotherapy beforehand killed off some of the cancer that had spread to the surrounding lymph nodes versus those that didn't have it beforehand. And in fact, about 30% of the patients who had gotten the chemotherapy and the radiation when they had the surgery, and the pathologist diced up the tumor and looked at it, they couldn't find any residual cancer cells left behind. So about 30% had an excellent response to the chemotherapy and radiation. And it was reassuring that giving the radiation and chemotherapy before the surgery did not have an adverse impact on the ability to do the esophagectomy, meaning the toxicities or potential side effects from the radiation did not increase the likelihood of having severe complications or dying from the surgery itself. So that was reassuring. This is a diagram that looks at how likely the cancer was to come back in the two approaches. For the patients that had, for the patients that had surgery alone, over time, about 32%, this is the white area, had no recurrence. About 28% had recurrence in distant organs. 22% had a combination of distant and local. And 18% had recurrence in the immediate surrounding tissues around the surgical site. Whereas the patients who had the chemotherapy and radiation beforehand had a greater chance that the cancer never came back. So 52% of those patients, the cancer never came back versus 32%. The chances of having it come back in other organs was about the same, but then the likelihood of having it come back in the surrounding tissues around the esophagus was significantly lower. And then Dr. Yoon did a nice job sort of walking us through survival curves, which are what oncologists often look at in terms of evaluating the success of a treatment. And again, it looks at from the time of the intervention, walking out to the right, the amount of time that passes, and the percentage of patients that are still alive. And so in this trial, of the patients who had the surgery alone, about 33% were alive at 5 years after the start of treatment, whereas the patients who had the chemotherapy and the radiation before the surgery, followed by the surgery, about 47% were alive. So it increased the proportion of patients that were still alive at 5 years after treatment. And then looking even out at 10 years, again, we see of the patients who had the surgery alone, 25% were still alive. In the patients who had the trimodality treatment or the chemoradiation and surgery, 38% were alive. So we see a meaningful improvement in the cure rate with long-term follow-up in the patients who had the trimodality therapy. So again, this really established trimodality therapy as a standard treatment paradigm for these patients. So again, in summary, this trial showed that for patients with operable esophagus or GE junction cancer, giving the chemo and radiation beforehand increases the likelihood of a complete resection. It doesn't negatively impact the surgery. It reduces the recurrence risk and increases the survival. What about patients who are not candidates for a surgery due to age or other comorbidities? There's a trial that was done that looked at either using radiation by itself or radiation combined with chemotherapy, so a 5-week course of radiation alone or combined with chemotherapy. This trial showed that the combined treatment causes much more side effects than radiation alone. So the chemotherapy enhances some of the side effects of the radiation treatment. So both severe and life-threatening side effects are greater if you give chemotherapy and radiation together versus radiation alone. However, the combination significantly reduces the likelihood of the cancer coming back, either in the esophagus itself or in other organs. And the combination treatment significantly increases the duration of survival and likelihood of longer-term survival versus using single modality, in this case, radiation treatment alone. So to summarize, for patients that have localized disease but are not candidates for resection, combined chemotherapy and radiation is superior to radiation by itself. It does cause more toxicity, but it reduces recurrence and improves survival, and is considered standard of care for these patients. I showed you some data from an older trial, more contemporary outcomes for patients who have esophagus cancer and are not candidates from surgery and are treated with combined chemotherapy and radiation. On average, patients live about 2 to 3 years, and about 30% of patients are alive at 5 years after treatment. So certainly we have a long ways to go in terms of increasing our outcomes or improving our outcomes, but there is a proportion of patients who can be cured with chemotherapy and radiation. Just to touch on the role of palliative radiation. So as we mentioned, patients that have metastatic disease or the cancer has spread, radiation is a useful treatment for shrinking the tumor in the esophagus and improving swallowing function. When we're doing it in this context, we will typically give a shorter course of treatment. So instead of a 5-week course of treatment that we would do for patients that have more localized disease, where the goal is to try to cure the tumor. In this context, we'll do a 1 or 2 or 3-week course of treatment, and this can be given either alone or combined with chemotherapy. And a majority of patients will have some improvement in their swallowing with the use of even more abbreviated courses of radiation treatment, depending on the study that you look at. Many of the studies show that 3/4 to sometimes even higher patients will report improvement in their swallowing function for several weeks to several months after the treatment. Moving to gastric cancer, we'll spend a little bit less time on this. The role of radiation therapy for tumors located solely within the stomach, so not involving the esophagus, but solely within the stomach. Radiation is not used as frequently in that context for a number of reasons. So for patients that have localized and resectable tumors that are confined to the stomach, typically the treatment paradigm is perioperative chemotherapy and then a surgery, and it's only select circumstances where we would consider adding radiation treatment. If a patient has a localized tumor but they're not a candidate for resection for one reason or the other, or the tumor is growing into other organs such that it would be challenging to remove the tumor, in those circumstances, radiation is more commonly used, oftentimes after an initial course of treatment with chemotherapy. The radiation can be used to try to downsize the tumor to make it potentially resectable, or again, if a patient is not a candidate for a surgery, chemotherapy and radiation could shrink the tumor and help relieve the symptoms for a period of time. And then for patients that have metastatic stomach cancer, short courses of palliative radiation can be helpful to address symptoms such as bleeding from the tumor, pain, or obstructive symptoms from the tumor. Just wanted to touch on one study that was done a while ago now, about 20 years ago, that looked at the role of radiation for patients with stomach cancer. This was a trial done across the United States, and it took patients who had initial surgery for their stomach cancer. So as I think was mentioned previously, we more commonly will do chemotherapy first before considering surgery, but at this point in time, 25 years ago, it was more common that patients would go to surgery first, and then we would consider treatments afterwards. So these patients had surgery as their first treatment, and then they either were observed, meaning they didn't get any further treatment, or they got a course of radiation and chemotherapy after the surgery. So this is a 5-week course of radiation as well as some chemotherapy. And in this study, giving radiation and chemotherapy after surgery did improve outcomes. The median time that patients lived was longer, and the percentage of patients that were alive at 5 and 10 years after treatment was higher in the patients who had chemo and radiation after the surgery. Now, as we mentioned, the application of this trial to the current era is a little bit challenging because a lot of things have changed. Surgery has gotten a lot better for stomach cancer in 2021, and we now commonly will give chemotherapy prior to considering surgery. So in light of these advances, as mentioned, radiation is not as commonly used for stomach cancer. However, there are certain circumstances, like we mentioned, where radiation still can play a role. Again, it's more commonly patients that may not be great candidates for surgery, or if the tumor is very advanced and there's concern about the removability of the tumor. In those circumstances, there can be a benefit in adding radiation treatment to the preoperative approach. Just to talk a little bit more about how radiation is given and sort of the patient's perspective of things. For tumors that are in the upper esophagus, for the treatment, we'll make a mask that goes over their head and shoulders that kind of keep them in the same position every day for treatment, and so they lay down on a table in this position. For tumors that are down in the lower esophagus and stomach, we want their arms up out of the way so that the radiation beams aren't going to come through their arms. So we'll make a mold that supports their head and their shoulders to keep them comfortable. We ask patients to come with an empty stomach for treatment. If a patient has a large meal before they get a scan or come in for treatment, their stomach can fill up and distend, and so it can move around the area that we're wanting to treat with the radiation. And so ideally, we want the stomach in the same position every day, the same distension every day. So typically the best way to achieve that is to have patients minimize their oral intake for about 3 hours beforehand. The two main types of treatments that are used for esophageal cancer are photon treatment. This is the most common type of treatment that's used, delivered by something called a linear accelerator. So the patient lays on the table and this machine rotates around. A newer type of treatment is called proton beam radiotherapy. This is a picture of the treatment room here in Rochester, and it's a much larger piece of machinery. If we could peel away the walls, you'd see that this is actually a 3-story apparatus to swing this around the patient. So this is a much more expensive type of treatment, much more expensive equipment to build in a facility to be able to deliver. So currently, there are about 30 or 35 centers in the United States that have this technology. Pretty much every other center in the United States has photon-based treatment. The side effects that we can see as a person's going through a course of radiation treatment, the esophagus can get inflamed and sore and swollen from the radiation treatment. That typically builds during the course of the treatment. So usually first couple of weeks, patients won't notice much. But then once they hit week 3 or 4, the esophagus really starts to get inflamed, and it makes it difficult for patients to swallow. They have a lot of pain. We work closely with them to help them out and support them through the treatment. Oftentimes they need to modify their diet to softer or pureed foods. We can give IV fluids as needed. We work closely with our dietitians to help try to optimize their nutrition. We have sort of a pathway of pain medications that we use. We typically will start with Tylenol, and then if that's not controlling it, go to viscous lidocaine. That's a numbing medication that they can drink that goes down and sort of numbs up the esophagus. And then if that's not cutting it, then many patients will need to use narcotic analgesics, things like oxycodone or morphine, for a limited period of time until they get through the treatment and start to improve. In spite of that, about 5 to 10% of patients will need a feeding tube to bypass the area of soreness and discomfort. So if a patient's really losing a lot of weight and getting dehydrated, then we would need to consider going that route. And again, it's about 5 to 10% of patients. They can lose their appetite related to the chemotherapy and the radiation. They can get nausea and vomiting. They can feel tired. The skin on the chest or back can get sore. The acute side effects, again, reach their peak around the end of the 5 weeks of treatment and kind of stay at their peak for a couple weeks afterwards, and then they slowly start to get better over the next several weeks. We can see some late effects related to radiation treatment. If the patient does not undergo an esophagectomy, or meaning they have definitive treatment, some patients will develop scar tissue or stricturing in the esophagus, which can make it difficult for food to pass through. And they may need to undergo an endoscopic or EGD procedure where they go in and they gently stretch out the esophagus, and that may need to be repeated depending on the circumstance. There's a small risk of injury to the surrounding organs, such as the heart and lungs, related to the radiation treatment, which may not become apparent for several years after treatment. There's been improvements in both hardware and software in delivery of radiation treatment. This is how radiation was delivered in the 70s and 80s. They would take an X-ray of the chest and then draw a big square, and a beam would fire from the front and hit everything all the way through, and a beam would fire from the back and hit everything all the way through, and would give a lot of radiation exposure to the heart and the lungs. As we moved into the 1990s and 2000s and 2010s, there's been improvement in the hardware that can sort of sculpt the radiation beams and treat from lots of different angles. And then computer planning to help optimally design a radiation plan in different angles and modifications of the beam to try to put the highest dose of radiation in the tumor and reduce some of the radiation going to the surrounding organs like the heart and the lungs. As we mentioned, the most recent advance is proton beam radiation therapy. Again, this is sort of we call it color wash, showing the intensity of the radiation treatment, the red being the highest intensity, and then moving down green and blue, lower intensity. And so ideally, we put all the radiation into the esophagus and surrounding tissue and none of the radiation in the surrounding organs. And with IMRT, which is the most sophisticated photon or X-ray type of treatment, we can put the highest dose there, but we do get a spray of radiation going through the heart and lungs. And so the appeal of proton treatment is you can use 2 beams that come from the back, and they drop the radiation right on the esophagus and can minimize the amount of radiation going to the heart and the lungs. Really, the esophagus sits in a tough spot. It's right in the middle of the body. It's right behind the heart. It's right between the lungs, and it's right in front of the spinal cord. So proton radiation does a better job in most instances than the photon treatment in getting the radiation to the esophagus and minimizing spillover into the surrounding organs. This is another view a little bit further down into the abdomen. Again, we can see the more conventional radiation gives a spray of radiation to the liver and the intestines and the stomach, whereas the proton radiation is a little bit more focused. This is another view of this, again, sort of looking head on. You can see there's better sparing of the lungs and the intestines, and then this is looking from the side. Again, the proton radiation, because the beams stop, you get sparing of the heart and the anterior structures. As I mentioned, proton therapy is only available at about 30 centers in the U.S., and many of those are fairly new centers. So there's fairly limited data looking at outcomes with the proton treatment versus IMRT, but the early outcomes, including data we've generated as well as MD Anderson, were the two centers that have the most experience with proton therapy for esophageal cancer. There is suggestion in the early data of better quality of life, lower heart and lung complications, and then interestingly, lower immune suppression with the proton treatment. MD Anderson tried to do a study where they directly compared proton therapy and IMRT. So patients enrolled and they had to be willing to, based on the flip of a coin, have their treatment decided for them. So they tried to directly compare to be able to better quantify the differences between the treatment. Their hypothesis was that the proton treatment would reduce toxicity. They showed that the proton treatment, in fact, did reduce radiation dose to the heart and lungs. It did reduce lymphopenia, which is depressed blood counts, and it did lower the toxicity burden compared to the IMRT. This is a fairly small study. There were only about 100 patients that were enrolled in it. And looking at survival, there weren't any dramatic differences between the two treatment approaches, but that really wouldn't be expected given the number of patients that were in the trial. There's now an ongoing larger national trial that's trying to directly compare proton radiation versus IMRT. This is being run through the NCIs. This is an NCI-funded national trial. And the goal is to enroll 300 patients, and they'll get either IMRT or proton. It's a randomized trial. Patients don't get to pick which treatment they get. Providers or physicians don't get to pick which treatment they get. These trials are hard for patients to consider enrolling in. A lot of patients will want to make a choice on what type of treatment they want. So this trial has enrolled about 50 patients and has been open for 3 years. The hypothesis is that the proton treatment will either reduce major cardiac and pulmonary side effects and/or improve survival. So in summary, radiation therapy is an important treatment modality for patients with esophageal gastric cancer. For tumors in the esophagus and GE junction, it can be used as a preoperative treatment prior to surgery, as definitive treatment for patients who are not good surgical candidates, or as palliative treatment to relieve dysphagia from the primary tumor. For stomach cancer, it's used more selectively and less commonly for localized patients, and again can be used as a palliative treatment for symptoms related to the primary tumor. It's typically given over 5 to 6 weeks with chemotherapy if it's localized disease versus oftentimes we use a shorter course of treatment in a metastatic or palliative setting. The acute and late side effects are predominantly due to irritation of the esophagus and stomach, and then longer-term scar tissue in those organs. And newer and advanced radiation techniques, such as proton therapy and IMRT, can reduce radiation dose to the heart and lungs and could reduce the likelihood of having injury related to those organs. Thank you.
Vâng, bài trình bày đến đây đã kết thúc. Cảm ơn các bạn đã chú ý lắng nghe. Nhớ like, share và subscribe để theo dõi các bài học tiếp theo. Xin chào và hẹn gặp lại.